So, okay, I shall begin. So, coronary catheterization. This is a very commonly done intervention since cardiovascular diseases are one of the most deadly, as well as one of the most common types of diseases that we as physicians face today. So, catheterization, given that it is very commonly performed, we should also have technologies that are actually aimed at developing to allow physicians to have a better look at what is going on with our own heart vessels. So therefore, today I will be introducing the latest imaging techniques that are introduced for coronary catheterization. So before we begin, let me introduce to you what coronary catheterization is. So coronary catheterization refers to the insertion of a catheter inside the coronary circulation of the heart for diagnosis as well as intervention. So in this case, for catheterization, we can recognize any form of occlusion, stenosis, thrombosis, as well as aneurysms that are present in the vessels of the heart. We can also use the catheters themselves to measure the blood pressures within the coronary arteries to determine whether the pressure is too high, such that cardiovascular accident will happen. Of course, there are also rarer uses, such as detection of congenital defects of the heart, as well as adjacent vessels, though that has mostly been replaced by echocardiogram, since that is non-invasive compared to coronary catheterization. So how do we approach, how do we insert a catheter into the vessels of the heart, given that the vessels of the heart are only talking about 0.2 millimeters to 2 millimeters. So in this case, we are actually going to insert the catheter from a larger artery, which in the usual case is going to be the femoral artery, which is located around at the medial groin. And we will, a cardiologist will basically open an incision and insert the catheter from an opening from an opening that allows entry to the femoral artery. Alternatively, if the femoral artery is unable to be used as an introduction, which is usually quite rare because after all, you have two femoral arteries, one on the left and one on the right, then you can use the radial arteries instead, because those are also large enough for the catheter to be introduced. So in this case, usually general anesthesia does not have to be used. Local anesthesia will be quite enough, such as lidocaine. And therefore, since no general anesthesia is used, you don't need to do any sort of intubation. And then we will try to visualize it usually with fluoroscopy and accompany it with percutaneous coronary interventions, such as angioplasty. And of course, there are also others such as transthoracic aortic valve replacement, etc. So basically, this is a conclusion of what catheterization will be like what the procedure of catheterization will be. So the tube will be inserted through the groin in order to reach the blood vessels. And then we will inject some dye so that it can appear on X-ray, more on that later. And then the cardiologist will look for the blockages as well as any other unrelated tissues. And then therefore, at the same time, insert the catheter to actually make repairs. Since as cardiologists, cardiologists want to minimize the number of times that an invasive procedure is done. So therefore, they will only attempt to catheterize the patient every time that a cardiovascular accident, for instance, ST elevation myocardial infarction happens. So imaging modalities. So the most used form of imaging modality is going to be angiography. So I believe this should also be covered in the pre-con syllabus, I think. So angiography is basically where the cardiologist inserts the dye into the blood vessels, and therefore they will enable a clear imaging for the X-rays to see, firstly, where the catheter is, and secondly, whether there are any abnormalities, structural abnormalities in particular, that can be shown on the X-ray. So usually, as you can see from the diagram on the right, you can see that there is a narrowed artery right here. So this is the usual presentation for someone who is having a heart attack, for instance. You'll find that there is a certain segment of the artery that has been narrowed, and therefore at that position, you will perform a percutaneous coronary intervention. So in this case, we do note that it requires the injection of radio opaque contrast, and it also takes still images. So there will be some sort of delay, but given the current technology, it allows us to take images at 15 to 30 frames per second in order to allow us to have actually real-time monitoring, so that we can use it as guidance for inserting the catheter and finding where the lesion of the artery is. So here is an example of the typical coronary angiogram. As you can see, the three coronary vessels are very clearly shown right here, and you can see the segment with a significant narrowing. But we should note that angiogram only presents as a 2D image, so we are unable to see from other perspectives, since after all, the patient is lying down and therefore the X-ray can only be taken from one direction. So that is a very great limitation. There's also the fact that the structural change as shown in this diagram is actually very severe. Most of the time, when someone has a heart attack, they will have some structural changes, but there are some patients that do not show structural changes yet they already have heart attacks because, for instance, there's a thrombus or there's a segment of narrowed artery that is otherwise usually through. But in this case, something happened, say, for instance, a thrombus, as I mentioned, and that causes a heart attack, but that cannot be visualized on an angiogram. So CT angiogram is another imaging modality, but that is non-invasive, and that in fact does not require the catheter to actually be inserted. So the benefits compared to the angiogram is that it also provides a clear look of coronary arteries for diagnosis, as well as evaluating the prognosis of the patient. It is non-invasive, and it has a very high sensitivity and high negative predictive value, in that a negative test results mostly rules out coronary artery disease. But of course, there are also its limitations. Firstly, it requires contrast. And given that it requires contrast, there are a lot of contraindications that come with it. For instance, if the patient has renal impairment, you cannot use contrast. The same thing goes with angiogram, because as I've mentioned, angiogram also requires a dye, and that dye also will cause that dye is also contraindicated in patients who have renal diseases. And again, it only provides a 2D image. It is also less specific than coronary catheterization and angiogram specifically, because after all, it is a non-invasive procedure. And as I've mentioned, there are a lot of contraindications. So apart from renal impairment, a relative contraindication will be pregnancy. And many other absolute contraindications include hypothyroidism, pheochromocytoma, because it can lead to an adrenal crisis or thyroid crisis. And then there's also the allergy to a contrast media. So as you can see, this is what CT angiogram looks like. So the typical image of CT angiogram will be the one on the right. So you can see the three coronary arteries, right coronary artery, left anterior descending, as well as the left circumflex artery. So they're very clearly seen. So you can actually see what goes on with these three big vessels, basically. So we can attempt to create 3D reconstruction. This is a very commonly used, even though it sounds very new and sounds very professional, but it is a very commonly used technology for basically all types of CTs, as shown on the diagram on the left. So in terms of 3D reconstruction, we can actually, modern technology has already allowed a very clear image of 3D reconstruction, such that we can look at the subarteries like the branches of the three great coronary arteries themselves, in order to see whether the sub branches are also in danger, whether there is any stenosis, thrombus, etc. So we can see from this image right here, this is a photo of a 3D reconstruction. It allows a better visualization of the extent of narrowing from all different types of angles. So in the program itself, you will be able to actually rotate this sort of model of the coronary arteries so that you can see which parts are actually narrowed, and therefore you can use that as guidance for percutaneous coronary interventions. So this will be very useful since I've mentioned most of the previous angiograms are only presented in 2D. With 3D reconstruction, you can actually have a look at the different narrowing sites from different angles that might otherwise be occluded when you are actually looking at a 2D image. But even those are not golden standards. 3D reconstruction, etc. These are all technologies that are 20 to 30 years old. So what are the new gold standards? Or I should ask, why do we need gold standards? So firstly, the newer forms of technology is intravascular ultrasound. This technology around has 20 to 30 years of age as well, but it is only more recently used in the recent 10 years or so. So intravascular ultrasound essentially represents where you insert a catheter into the coronary vessels as usual, but instead that catheter itself includes the capability to actually use ultrasound to determine what is inside the lumen. So it enables the topographic assessment of the lumen area itself. It can also assess the plaque size, distribution, and even the composition of the plaque itself. So in general, how to interpret is that lipid-laden lesions will be hypoechoic, and by hypoechoic, it usually means grayish color. And then fibromuscular lesions have lower intensity echoes. Those will be even closer to a darker gray. And then fibrous and calcified tissues are echogenic, and in layman's terms, that will be whitish color. So this is the catheter. So usually it is around 2 millimeters, and now it is only getting to go smaller and smaller, so that we can use it for not only adults, but also children as well, since as you congenital heart diseases are actually very common, and these can also be used. So we can use this form of catheter to actually insert into the lumen itself, and we can visualize what's happening inside the lumen instead of the 2D images that I've mentioned. We're only looking at the outside. So this is a diagram for the intravascular ultrasound. So from the intravascular ultrasound, you can actually see what the lumen, what the contents inside the lumen are basically. So this is a very textbook picture of atherosclerosis and atherosclerotic plaque. Previous technologies do not allow us to visualize what's inside the lumen, but IVUS, intravascular ultrasound, actually allows us to do so. So as you can see from the larger diagram on the bottom, you can see firstly, the lumen itself is actually circulated by the yellow circle that is right outside. So what surrounds the lumen itself would be the tunica media, and the tunica externa would be the grayish border that is right outside. So if we look at the lumen, that will be much clearer. We can see right in the middle, that will be our catheter, right in the middle, as well as the line basically that surrounds the catheter. And then we can actually measure, since we are actually essentially taking pictures, we can measure using the program to determine the lumen area, and it's intended like the original lumen area, which we can see is 20.7 millimeters squared, compared to the lumen area itself, which is only 7.7 millimeters squared. So we can see that there is quite a significant blockage in the arteries. But even at this extent of the blockage to the arteries, since the arteries can still allow blood to actually come through, you won't see anything on the angiogram. You won't. But you can clearly see the atheroma, which in this case is the atherosclerotic plaque, indicated by the clump of blood cells and cholesterol, basically. You can see it very clearly with IVUS. And with this, you can identify lesions that are otherwise absent on angiogram, and you can actually perform the adequate interventions in those areas. So the advantages over angiography is that it allows better visualization of the entire vessel wall, especially the contents inside. It allows of the early identification of early atherosclerosis, which is not detected in angiography. It allows potential analysis of plaque composition to identify vulnerable plaques, even though most of the plaques are usually contain cholesterol. If we can determine that the plaque itself has more blood cells than cholesterol and has the high probability, a high risk rather, of developing into a thrombus, then you can remove it immediately. So therefore, IVUS currently serves as the gold standard for percutaneous coronary interventions, in that it is able to determine exactly the sites where the arteries are having a problem, and therefore cardiologists will be able to perform interventions on those sites accordingly. But of course, there are still limitations. IVUS is not the latest technology. It is still invasive, as I've mentioned, and it is very operator dependent, as with all forms of ultrasound. And as with all forms of ultrasound, yet again, there will be a very steep learning curve. So the latest technology that we are using is the intravascular optical coherence tomography. So essentially, this is the light counterpart for ultrasound. So if you know, the ultrasound essentially uses sound waves to releases sound waves from the catheter itself, right? And then it reaches the lumen of the wall, and then it reflects. And based on the different reflections, we can determine it can be interpreted as an image by the program itself, and therefore you can visualize it in terms of different echogenicities, if you will. But for optical coherence tomography, you are actually using light, so you are essentially shining a light bulb, but in this case, it's going to be near infrared light, so you won't actually see any light coming from the catheter itself. So infrared light is radiated out to the lumen itself, and then the lumen as well as its contents will reflect back to the catheter to allow it to receive signals. So since compared to ultrasound, light it still has a much higher frequency in terms of wavelength, a much shorter wavelength, we can actually get a much higher resolution for the image. So as I've mentioned, the advantages, it has a much higher resolution, up to 15 micrometers compared to IVUS or angiogram. It allows understanding of morphology and optimizes stent implantation. The good thing about this is that for IVUS, it is really difficult for you to insert the catheters back into the vessel once you have placed the stent there. But for ILCT, that's not a problem. And it is also generally safe, around the same similar safety as IVUS. Around 5% of people get complications, but otherwise nothing happens. But the limitation is that it requires contrast injection still. This is the fact, this is the reason that it has not completely replaced IVUS yet, because intravascular ultrasound has much less contraindications. So this is an image of ILCT essentially. So as you can see the catheter, which is denoted by the asterisk right here. We can look at picture A, which is the top left-hand corner. So the asterisk marks the catheter itself, and we can see the lumen clearly surrounded by this yellowish border, which is again the tunica media, and we can see that the lumen is actually distorted. In this diagram, we can't see an atheroma because it does not exist, but we can already see some sort of structural changes which may suggest of possibly forming atherosclerotic plaque. And it will be much clearer compared to IVUS because it has a much higher resolution. and the fact that it is a coherence tomography in the case that it is CT. So with all CTs, as I've mentioned, 3D reconstruction is possible. And in this case, 3D reconstruction can be done from within the lumen so that we can see what is inside the lumen rather than the general structure of the entire lumen itself. So we can actually pinpoint, firstly, where the vulnerable plaques are, and secondly, it also allows us to determine whether the structural integrity of the coronary vessels themselves is intact. But even this latest technology still has breakthroughs, and there are several different directions of breakthroughs that we can do to better optimize the imaging techniques of coronary catheterization. So firstly, in modern days, in fact, cardiologists in the catheter lab will use all of the aforementioned imaging modalities in order to, for a normal patient, like not healthy patient per se, but a normal patient, say without renal problems, etc., such that we can actually better optimize, firstly, the stent placement, the placement of the balloon stent itself, as well as the as well as optimizing the different sites, as well as understanding the prognosis of the patient after the stent implantation. So this diagram essentially shows, firstly, we can determine where the catheter is via the angiogram, because usually when you insert the catheter into the lumen, you're more likely to get lost. In layman's terms, you're more likely to get lost because you basically can't tell where the end of the tunnel is and where the beginning of the tunnel is. So you will need the help of angiogram to actually identify and coordinate where the catheter is. But then you will also get intravascular optical CT, as well as intravascular ultrasound. You use both of these modalities together to see, to complement each other basically, and see whether there are lesions that is otherwise missing from the angiogram itself. So currently for catheters, because you will want to combine all of these imaging modalities together. So sometimes you will have to insert more than one catheter. But inserting more than one catheter actually increases the chance of complications. So what do you do? So there are many different other forms of technologies that are combined into the development of imaging techniques. And one of them is actually 3D printing. So with 3D printing, you can actually develop catheters that are small enough for you to actually make a ton of different imaging modalities to combine them inside the same catheter. Like in this new recent paper in 2020, for instance, it shows that it demonstrates a design for a catheter that includes the intravascular optic ultrasound as well as intravascular optic CT. So both of these have come together to form one single catheter. And even more than that, you can actually use the same catheter to insert a balloon angioplasty. And that will be the next step, basically. So one catheter do everything. So 3D printing will be one of the directions since it requires high precision. And then another form of development is AI. As Zach mentioned, it is a very, very useful form of program that is very helpful in the medical industry, especially interpretation of imaging. So with all these new forms of imaging, as I've mentioned, especially for more difficult types of imaging, such as intravascular ultrasound, it is very operator dependent. But artificial intelligence basically removes that criteria, such that more physicians who are newer in training will be able to interpret the images better. And more than that, apart from interpretation of the images, they can also do 3D reconstruction at a better rate. And with 3D reconstruction, they can the artificial intelligence program can essentially perform different tasks, such as, for instance, identifying different sites based on the 3D reconstruction that might otherwise be very difficult for physicians to look for, or at least it is very time consuming. So if you're interested, this AI technology is developed by Abbott. It's quite a large company in the US. So and they just got FDA approval this year, so it's pretty recent. So lastly, you would ask, what sort of uses are these for? Like, why do we need such good imaging techniques, given that we are just inserting a catheter and then inflating a balloon? Well, there are more, there are newer approaches to actually do intervening with people with cardiovascular diseases, and I would like to introduce one of them to you. This is going to be atherectomy. So atherectomy essentially refers to the fact that you are inserting the catheter, but in this case, the catheter acts as a sort of drill, and the drill will actually essentially remove the atheroma from your vessel entirely. Because for angioplasty, you are essentially just blowing up a balloon and then pushing it away. You're not clearing the atherosclerotic plaque away, and therefore the structural integrity of the vessel is not repaired, basically. So with the mentioned technology, you can imaging technology, you can actually better visualize what sites you will not want to do different types of interventions. And in this case, you can better use atherectomy, for instance, as a new means of actually removing the atherosclerotic plaque that is otherwise not visualized by all the forms of technology, or even echocardiogram. Like those essentially cannot show it. So here's a video explaining what atherectomy is. So please enjoy. Is there any voice? Okay.
Not really.
Not really.
Oh no, is there no sound? Is there no sound?
Yeah, there's no sound, but I think it's okay. We can still see the.
Fine. So maybe I'll be the one to explain. So
Yeah.
yeah, let me play it. So essentially, you can see that it uses a vortex structure similar to that of toilets, basically. So you use that as a drill to actually extract the atherosclerotic plaque in this case, as well as the thrombus, which is represented by the red stuff that you can see. So it continuously aspirates it so that it can essentially provide a larger area for your blood to actually pass through, and it is permanent. Unlike angioplasty, which pushes it away, it doesn't clean your vessels. So yeah, and then essentially those materials will be aspirated and then they will be thrown away. So that's all. Thank you very much. And if you have any questions, please email me.
So actually, like when you like drill all the stuff, the debris, do they not cause any sort of clotting or inflammation as of reactions?
It's actually too small. Like inflammation, is when you actually damage the endothelium, right? Like in terms of this procedure, if you damage the endothelium, you will actually get some sort of response. And then if you drill away, of course, there is a risk of actually harming the vessels, but compared to angioplasty, is it actually similar in terms of the complication rate. So I can say it's pretty safe. But the main limitation for this is angioplasty is much quicker. Like you just blow a balloon and then take the catheter away. You can have a look at the website of Hong Kong Sanatorium Hospital. They actually attempted a world record for fastest angioplasty in the world. Even though they failed, they actually performed it in 47 minutes. Like this is impossible. Like 47 minutes includes everything, like local anesthesia, opening an incision, putting the catheter in, pulling the catheter out, done. So it's pretty remarkable. But atherectomy is still a new technology. Firstly, the catheter itself is very expensive. Secondly, the procedure is very expensive and time consuming. So angioplasty is still recommended right now.
Right. That's very
And there are tons of references. Okay.